Well, hello everyone, and thank you for attending today's webinar, which is Are You Prepared for a Workplace Twindemic? My name is Holly Foxworth. I'm a registered nurse here at Axiom Medical, and I'm joined by Axiom's Chief Medical Officer, Dr. Scott Cherry, and Emergency and Critical Care Physician at Houston Methodist, Dr. Rezvankhoo. And so they're going to explain what it is that we need to know, what a pandemic is, what the twindemic is, and what it is that you're going to need to know for your individual workplaces. Before we get started, though, I would like to briefly cover several quick announcements and just give you an idea of what you're looking at here on the webinar platform. At the bottom of your screen, you'll see that there's multiple application widgets that are there. They are all resizable and movable. There in the Resource tab, you can find additional information about white papers, Axiom's on-site mobile COVID testing and flu clinics, along with check-in to work and check-in to school information. Right there on the right-hand side of your screen, you'll see that on November 29th, so that's going to be 2 weeks from today, we're going to be hosting another webinar on recognizing and responding to suicide warning signs in the workplace. Obviously, anytime that there's a tragic loss of life, many lives are impacted, and we know that a lot of people have faced a lot of issues this year with the pandemic, along with the added stress of the quickly approaching holidays. So sometimes the best thing that we can do is definitely educate ourselves and know how it is that we can take action when some of those warning signs are recognized. So if you'll click right there on the right-hand side of your screen where it says Register Now, that button there, that's going to get you signed up without having to enter any additional information, and we look forward to seeing you there. As I've mentioned before this webcast series, it is a town hall type of format. We want to know what's on your mind and hear what your questions are, so please feel free to submit those throughout the broadcast using the Q&A widget. And then should we run out of time before we get to your specific question, we've also added a live stream follow-up on our social media channels. So that's going to be LinkedIn, Facebook, and YouTube. And so you can join us there next Thursday at 1 p.m. Central. A copy of today's slide deck and additional help materials are available there in the resource list, and you can also find some additional answers to common technical issues located right there in the help widget. Finally, an on-demand version of this webcast will be available after the broadcast, and it can be accessed using the same link that was sent to you earlier. We'd like to thank all of you who've been submitting questions to our webinar events using the coronavirus@axiomllc.com email address. We had some great ones that came in this week, and so we're going to be addressing those at the end. But for those of you that haven't used that form of communication with us yet, this is direct access to our team of experts. Obviously, we're invested in making sure that your schools, your businesses, that they're all able to succeed and thrive, and we've handled a vast number of cases throughout this entire pandemic. So whatever question that you may come across or challenge that you're facing, we've likely covered that with other clients across the nation, and we can quickly get you the answers that you're needing. So please feel free to utilize that email address at any point. So at this point, I'm going to go ahead and turn it over to our speakers, our presenters, Dr. Cherry, and let you introduce yourselves, and then we'll get started with preparing for a workplace twindemic. Dr. Cherry?
Thanks, Holly. Good afternoon, everyone. Thanks for tuning in. Just a little bit about my professional background. I'm board certified in preventive medicine, public health, and occupational and environmental medicine. I've spent about the last 15 years supporting either the military, corporate, or industrial operations. And it's been a pleasure to be part of this webinar series where we're helping explore how, as science unfolds, COVID-19 and how it's affecting our clients, our populations. And so, again, thanks for your turning in.
Dr. Rezvankhoo?
Yes, hi, my name is Kabir Rezvankhoo. I'm board certified in emergency medicine and critical care. I did my training in New York City or New York Presby, and then did my critical care training in Washington, D.C. Currently, I'm working out in Houston, primarily critical care full-time, and so I have experience with the COVID ICUs and also in the emergency department and what they're seeing since the pandemic.
I'm sure that gives you a first-hand view of what's going on, so we look forward to hearing what you can share, definitely. Well, we appreciate both joining us today. Just kind of getting things started. Dr. Cherry, speak to us in general about what this term is, a twindemic. What does that actually mean?
You know, as we come into flu season, while we're trying to help manage, COVID-19, we're really looking at trying to manage two outbreaks at one time, and so that's where the term Twindemic comes from. And so really it's the coronavirus outbreak, and every year we actually have seasonal flu, and so you'll see flu campaigns that support or try to provide protective measures like annual vaccinations, hand hygiene, environmental hygiene, cough etiquette, things like that.
And so, kind of breaking that down a little bit, let's dive into both the COVID-19 and the flu aspect. So maybe give us a overview of what COVID-19 is, and then we'll jump into the flu. I'm sure everyone has some basic knowledge, but just to kind of tell us a little bit about what's involved in that, what the common symptoms are that you're looking for, et cetera.
Sure. From a population health perspective, COVID-19 stands for Coronavirus Infectious Disease 2019, and so this was a new type of coronavirus that was identified in late 2019, and so coronavirus in general is not new to causing infections in humans, and really there's four types of coronavirus that are part of the infectious diseases that cause the common cold. But in the past 20 years, there's actually been two other outbreaks of a novel or new coronavirus that has not been seen previous. You have SARS and MERS from 2003 and 2012. Those outbreaks had a very high case fatality rate. So for every person that gets infected, what proportion would potentially die? And so you would have case fatality rates of 15 and 37% respective, and so a very high case fatality rate. Fortunately, with COVID-19, the case fatality rate is not that high. I think early on in Wuhan, there was a concern about also another high fatality rate because there wasn't a better understanding of the full prevalence or how many active infections were out there. But I'd like to kind of turn this over to Dr. Rezvankhoo too, to see about what he's been seeing in the ERs, in the ICUs from a individual, direct patient care perspective.
Yeah, so I think what we've been seeing with COVID-19, what's very unique about it is that it is very infectious, and I think the biggest problem with this is that the average duration of time where someone runs around asymptomatic is probably around 4 to 5 days, and probably around 5 to 10 days is where people start to develop symptoms, and so there's a lot of exposure that is happening in asymptomatic patient populations, and so the disease spreads, in a very cryptic way where asymptomatic individuals are spreading the disease. Now, what I'm seeing inside the hospital are those who have severe COVID-19 illnesses and warrant hospitalizations. So by that means, it usually is someone who has a very severe pneumonia and is requiring oxygen for some form of support. Now, when we get to mortality rates with COVID-19, I think the CDC is probably casing it around 2.3% case fatality rate. But what that means for us is if you're young, if you're healthy, and you probably are going to be okay. I mean, the odds are totally in your favor. In terms of the rates per 100,000 population, when you look at those that are passing in the hospital, it's really those that are 75 years and above. But it can also happen to those that are 40 to 74. But it also comes with risk factors. So those who have underlying cancer, some form of chronic kidney disease, lung disease, diabetes, hypertension. I think probably the biggest one that we've noticed that really has had a huge impact on our mortality rates comparing to other nations is probably obesity. So I think that in itself has had an impact on overall mortality rates.
And so the patients then that you've been treating, have they required a lot of intubation and ventilators and things that come along with that?
I work with in the intensive care unit, so I see only the sickest ones. Okay, and so the individuals that I see, by and large, are over the age of 65. Or if they're younger, between the ages of 40 and 65, they usually have a lot of chronic comorbidities, which make their bodies much more susceptible to the virus. Diabetes, heart disease, kidney disease, those who smoke or have emphysema, and obesity. So the risk factors really can have an impact on the severity of illness. And so, but the age is still, I think, one of the strongest risk factors by itself.
Well, let's talk about flu. You guys want to give us just kind of an overview of the flu as well, and then we'll kind of get into some of the similarities and differences between the two.
I can take a shot at it first, and then I'd like to hear Dr. Rezvankhoo's view on it as well. And so I think flu we're quite complacent with. Every year, really, there's a new strain of flu that can cause, a significant amount of disease in America and across the world. And a vaccine is created every year to try to really target what they expect the genetic drift would be in the flu. But, the flu is quite capable of changing its genetic makeup enough to where it's relatively successful in causing an outbreak every year. And there's a significant amount of deaths every year in, I think, high-risk individuals that Dr. Rezvankhoo was alluding to. And what's interesting is, and I'm probably stealing a little bit of thunder from the next slide, but comparing maybe for young individuals and children, the flu actually can be have high rates of morbidity and mortality, where we're not really seeing that with COVID. And so again, from a population health perspective, we're always trying to support our clients with proactive and preventive measures in providing vaccines on site or within a population, and trying to remove those barriers where people may not have time to go see their doctor to get, again, that vaccine, and then also promoting safe behaviors, which now are much more commonplace in this COVID area.
Yeah, I totally agree with Scott on this one. With COVID-19 and influenza, the symptoms are nearly exactly the same. You really can't distinguish it based on symptoms at all. In fact, when patients come in with cough and cold-like symptoms, we always describe it as an influenza-like illness. And with COVID-19, the symptoms that you see are going to be fever, cough, fatigue, decreased appetite, shortness of breath, and sort of muscle aches and pain. So those are the exact same symptoms of influenza. The difference is that in the adult population, there's a couple of differences. COVID-19 is a far worse virus to get than the influenza. And then secondly, influenza, we have vaccines for it, we have therapies for it, medications that actually reduce the duration of illness, whereas for COVID-19 we don't. So it's really important to try to separate these two diagnoses if possible, and we do it pretty much on every patient that comes in. We do both an influenza or a respiratory viral panel study, which identifies influenza patients, and then we also do COVID testing separately to make sure we can identify what's the culprit in these patients, because that's the only way to tell the difference, really.
So what would you say then, if you had to specifically identify what symptoms are different between the two? Where would you see that? Because there are some that are similar there, but what would you identify as really being the different symptoms for COVID versus?
I think the symptoms are exactly the same.
Okay. All right, so there's not, so like the loss of taste and smell and things like that?
I think that's more of the loss of taste and smell is not specific nor sensitive enough to say that this is what's going to differ. I think, unfortunately, social media has such a grab on people's minds that I think there was one person who was maybe an athlete that lost lost their sense of taste, and all of a sudden that's like the test to know to have COVID-19. But in fact, it's fevers, myalgias, and cough. I mean, you really can't differentiate just by symptoms alone. You're going to need testing.
And then in terms of the duration of when you're seeing symptoms and how long that those last, what would that range be?
So again, I mean, it's case by case. I think that the duration of illness varies. And well, I can say that the duration of illness, if you are a healthy person, could be 3 to 5 days for influenza. If you're a healthy person for COVID-19, it could be 3 to 5 days as well, or maybe 10 days. But you have to remember, a majority of these people are running who are COVID-19 can be run around asymptomatic for the first 5 days, and then they develop symptoms on day 5, and then maybe for another 5 more days they're symptomatic. So they've been infected and symptomatic for only 5 days, but their symptoms, their illness has been ongoing for probably 10 days or more.
Yeah, I've been thinking about this. Just let me add one extra point there. As we've been thinking about our guidelines and protocols to help differentiate flu and COVID, it has been exceptionally challenging. Even just trying to differentiate symptoms for COVID, I agree, there's a lot of support now that shows there's a large proportion of infected people are asymptomatic, and that also there's a tremendous amount of, there's a lot of evidence now that shows there's a lot of atypical symptoms that you would not expect in upper respiratory illness, where you have people with potentially no systemic signs like fever, chills, muscle aches, but potentially just gastrointestinal symptoms and things like that. So in general, when I look at these two infectious diseases, I'm quite comfortable with flu, and COVID is very challenging from a clinical perspective. You really cannot provide any of the symptoms that the CDC has listed as potential or probable symptoms. You cannot put weight to them about which symptoms would be more predictive than others. And so, again, it's just very, very challenging.
Yeah. So in terms of whenever we look at the workplace impact, because obviously that's kind of a little bit, that's what our focus is here, but so what are we looking at? We've talked about in great detail about, some of the things that you would need to implement and what could occur in the workplace from the COVID-19 aspect. But when you add in the additional piece of the flu, are there any additional precautions that they need to cover, or how could that impact their employees?
Mm-hmm. I can add a little bit here. Obviously we want to promote the safe behaviors and environmental protocols for hygiene and cleanliness that we do every year in flu. We've been doing that now for COVID. I think a significant change with COVID now is this idea that we've been promoting of zero tolerance of illness in the workplace. And so I think we're all guilty of coming into work when we're sick, potentially during flu season or just throughout the year, where we're dedicated to our jobs and getting our functions completed. And so it's somewhat of a badge of honor to come into work sick. I think with COVID now, we really need to shift to where we have policies and culture change to where, if you are sick, you should not be coming into work. And then additionally, the impact to workplace from a case management perspective, COVID has a much longer duration of social isolation requirements. And so really the primary working or guidance from CDC for social isolation would be to have at least 10 days since your symptoms have begun before you could return to work or go into public. And that timeline is much shorter for flu. Usually the working guidance for that is, 24 hours once symptoms have resolved, you could discontinue social isolation. And then another component is managing exposed but asymptomatic personnel. And so, we manage exposed personnel as keeping them out the whole incubation period of COVID-19. So the range of incubation period for COVID-19 is up to 14 days, with the median time being 5 days. So again, exposed employees to COVID-19, whether it's a household contact or a close contact, they're going to be out for 14 days, where for flu, if such a policy was to be enacted, would be approximately 5 to 7 days. So you have much shorter duration of incubation period, and also for those that are testing positive, presumed positive, or symptomatic, they would be out for a much longer duration of time.
Anything to add to that as well?
Yeah, I mean, I echo in with what Dr. Cherry is saying. I really believe that the duration of illness, the duration of time that you need to be out is different based on the CDC guidelines, and and the process of which we need to sort of isolate the individuals that are sick out and have the duration of illness be specific to the illness that they have will ultimately require testing. So I'm in agreement with what Dr. Cherry is saying.
Another point that has came up that we've had people ask about is, previously in the workplace that we would require, or you would have some employers that would require physician notes, verifying kind of that they had been sick, but that they could come back to work. We saw whenever COVID that was initiated that we kind of moved away from that about, requiring that people have notes before they come back, et cetera. Do you feel like that there's any similarities there in terms of how we should manage the flu from that perspective, or do you think that we should stay on the same path and just everybody out for the longer periods and then returning?
So in my opinion, I believe that flu and influenza, if you're just talking about symptoms and not having a diagnosis, are the same thing. I think when we talk about how long you have to be out of work or how long you have to be out of school, whatever that may be, is dependent upon what you have. If we don't know what we have, I would assume that you'd have to probably go the longer route of being out for 10 to 14 days and assume it's COVID-19. I mean, when New York City hit in March, everyone that showed up to the ER, many of which we never even tested because they were not hypoxic and they did not need oxygen therapy or warrant admission to the hospital. We would tell them, listen, we think you have COVID-19. You just have to go home and sort of isolate yourself. And so, overwhelming the healthcare system for doctor's notes, I think in the midst of a pandemic is probably not the right thing to do. I think if individuals can get tested, they can know exactly what they have, and then we can it'd be better for these workforce industries to actually have their own protocols in place to know how to manage their patients, because not every doctor is going to be up to date with the medicine. Not every doctor is going to practice the same way. And I think that in order for you to really effectively protect other employees, would be to bolster up some sort of a program where there's better monitoring and control of what's happening to the employees in the middle of a pandemic.
Before we get into some of the proactive measures maybe that they can implement there at the workplace, talk to us a little bit about the risk factors. Do they both have the risk factors that would be associated with COVID and the flu?
Yeah, I mean, ultimately, the risk factors or severity of illness really correlates with, risk factors, age being one of them. But for those of us who are in the years of working, which is probably somewhere between 30 to 65, let's say, there's going to be medical conditions that are going to make individuals higher risk or more susceptible, one of which is going to be just being overweight with a BMI of over 30, 35. Those who smoke, those who have heart disease, cholesterol, those who have underlying autoimmune diseases or cancer. So these individuals are very susceptible to getting sick, and that's just based off of the statistics of what we've seen happen across the world with COVID-19. The same is true for those who get influenza. I mean, when influenza hits, we definitely see patients with influenza in the intensive care unit, and again, it's based on risk factors. So those who have chronic lung disease, those who are very overweight, or those who have diabetes or high blood pressure that's poorly controlled. So all these variables are going to be risk factors. And so it's hard to really separate the risk factors between who's going to get sick, more sick, if they had influenza versus COVID. I think COVID in general is a far more serious disease than influenza for working adults, but I think at least for influenza, we have medications for it that you can take, whereas COVID-19, you just kind of hope that you don't need oxygen and don't end up landing in the hospital or in the intensive care unit.
Talk to us a little bit about implementing some of these proactive measures. I know we've had a lot of discussions whenever we in the early days of talking about screening employees and really looking at different factors that needed to be implemented, from everything from hand washing to face mask, et cetera. Are those the same types of measures that need to be continued and within the workplace to kind of prevent the spread of influenza and COVID-19?
Scott, I'll let you take this one.
Sure. Yes, I would say really the primary measures with regard to hygiene in the workplace or even in public, with regard to especially hand hygiene, where you're washing your hands frequently, you're not touching your face while in public, and then also cough and sneeze etiquette is really a major prevention component. And then what we're seeing again with COVID especially is trying to prevent any illness into the workplace. So having people screen themselves daily, whether it's just a personnel policy or some type of technological solution that helps kind of change the culture for one, but also shows compliance to screening. From an occupational medicine perspective, we are looking at what OSHA and some of the regulators are doing with regard to infectious disease preparedness plans that historically have only been issued in healthcare settings and research type of venues that deal with infectious disease. And now, COVID is almost considered presumptive work-related unless there's a very strong workplace investigation that can show more likely than not it was contracted outside of the work. And so I think this is now starting to show that general precautions like we used to do in the hospital, or what I used to do when I was in the hospital, I'm sure Dr. Rezvankhoo is still doing, but you really want to make sure that people are not coming into the workplace sick, and that every employer is going to be responsible to a degree for infection control. So kind of an interesting time in culture change in occupational medicine.
I can just add on to that a little bit. I think I mean, common sense is the most important thing from a healthcare standpoint. I mean, honestly, everyone getting vaccinated for influenza at least is good. Wearing a face mask really helps. Social distancing really helps. I mean, these have been great measures that have really decreased the risk of spreading the disease. In fact, there was a nice research study that was done that looked at healthcare workers and the risk of healthcare workers that are going into patients' rooms that are known to be COVID positive. And the risk of getting infected is lower to that healthcare worker as long as they have the necessary PPE and the policies and procedures than if they were to go into a person's room that is unknown or like in the community. And so I think the important thing of having a sort of a systematic approach to these kinds of scenarios is very important for overall health of people.
Dr. Terry, do you agree that you know, the concept of pre-screening, like what we've kind of done with the app, et cetera, of making sure that people are testing for what their health status is before they're actually coming into the office or they're coming into the factories, et cetera, that's a practice that would need to continue forward?
Yeah, I believe so, and I think with flu coming on, it's even more important because of the risk of having contagious illness in the workplace. You know, from a crude perspective, is almost doubling. And, you know, so again, if you can have a systemic approach to having employees screen themselves, doing some type of temperature check as well is also key. And I just want to echo too what Dr. Rezvankhoo was saying about wearing face masks as a primary prevention, especially with that large proportion of asymptomatic infected COVID cases. And then just to touch on environmental cleanings, usually most, you know, corporate offices or businesses will do cleanings once daily. I think during lunch breaks or just doing high touch areas, having someone do more frequent cleanings is also crucial. Having hand sanitizers, you know, throughout the building and also in the common places will help kind of encourage utilization of that type of hygiene practice, you know.
What would you recommend in terms of having conversations and just kind of educating employees? You know, we've got the holidays that are going to be coming up. We still have, you know, we now have flu and we'll have COVID-19. They've been very forthcoming and you know, kind of warnings that these cases may continue to rise, especially as we have people doing a lot of traveling and they're going to family gatherings, et cetera. So what type of education should they be providing their employees about personal behaviors?
You know, so part of our internal strategy in trying to assess risk for, you know, traveling employees is, one, looking at the area's infection rates. And so early on, there was very well-defined hotspots in the U.S. and in the world. And then over time, those infection rates became more homogeneous across the geographies. And so we started really pushing to encourage safe behaviors during travel. And, you know, obviously before face masks were fully or widely utilized and adopted, we were recommending that. I think knowing the crowds, if you're going to be in public areas, you want to be very mindful of only being nearby people who also have face masks, because really the face mask is protecting essentially everyone but the wearer. So you don't want to be in close contact with anyone without a face mask. You want to, again, maintain that hand hygiene and cough etiquette type of concerns. And then I also think from a general recommendation is everyone should see their physician to see about their current health status. Are they potentially in one of the vulnerable populations that Dr. Rezvankhoo was discussing? And so you may know you have certain chronic medical conditions, but this may be the perfect time to seize the day and try to optimize your health as much as possible through lifestyle change and through even medication management if needed. And there's probably a percentage of employees that don't go to a doc regularly, so they may not know they have prediabetes or high blood pressure or some other chronic medical condition. So I think it's a great time while there's not a huge surge in cases to determine if you might be in those vulnerable populations. And I don't know if Dr. Rezvankhoo, you have anything to add there?
Yeah, I mean, I definitely agree that with everything you're saying, and common sense goes a far way. And I think that with the weather getting colder, I think being in the southern states, we've been lucky with having warmer weather, and I think that people are going outside more rather than being indoors more. And so I would anticipate that as fall and winter kind of come forward, what will happen is that people will start congregating indoors more. And so I think that limiting your exposure to risk will obviously reduce the risk of getting sick. And so it's just a time where, in my mind, I'm just watching to see how things are going to go in the next coming weeks as the temperature continues to kind of cool down. But I think common sense goes such a long way, but primary prevention, hand hygiene, wearing a mask, all of these things can really make life a lot easier in the workforce. And I think, if everyone sort of had a standardized practice, it may even reduce the anxiety level that people are having.
Excellent point. We had lots of town hall questions that were submitted this week, and we've had lots that have been coming in even since you guys have been speaking. The first one was from Jill, and was saying that she was a little bit worried about their employees assuming that their illness was COVID-19. So she was asking, are there specific pre-screening questions that would rule out COVID-19?
Yeah, that's, I think a very challenging professionally, it's very challenging for me to, I have not been able to come up with a screening protocol that is specific enough to differentiate between COVID and flu. And I echo Dr. Rezvankhoo's approach that testing would be really needed to help differentiate those two. And so we have come up with, testing solutions that either exclude COVID and can kind of default to an alternate diagnosis, or potentially do more specific testing with regard to flu, strep, RSV, and things of that sort. So again, I think from just a screening questionnaire, it would be very difficult to come up with something sensitive and specific enough to differentiate the two.
Yeah, I've got a question. I'm sorry, I've got a question for Scott, because this is something, the co-infection rates, if you remember when the COVID first came out, what we were doing was we were saying, okay, if they're influenza positive, then we're not going to do a COVID test. At least that was sort of the practice of a lot of hospitals. But we nonetheless, as people were getting stayed sicker or got worse, like, well, this is kind of strange, we started doing testing for both, and we saw co-infection rates of up to like 20-30% in some of our patients where they have both influenza and COVID. So I'm wondering if when you're saying you can do a test to do one and not the other, I'm wondering, is that just you're doing like a battery of tests on everyone, or is it you're somehow assessing them for, let's say, for strep or
Yeah, no, that's a great question. And I know we've discussed this on and off over the course of the pandemic, and I think your direct experience in the hospital may be maybe a little biased towards kind of having a heavier co-infection rate, but there's definitely evidence to have co-infection in the milder cases as well. Probably it's significantly lower than what you're seeing in the hospitalized or ICU patient population. And so we do have those discussions with our clients about, risk management and how much to invest in an employer-sponsored testing, or do we defer to the employee's personal physician? And so we're kind of just in the early phases of that now, but right now, from what I've been seeing from a kind of the general population, the co-infection rate is low, and it may be below the risk tolerance of some of our clients. So if we can feel relatively confident COVID's excluded, then we would assume it's one of the other pathogens, and so we look at the longest duration of symptoms or return to work guidelines for that. So again, COVID is usually the longest at 10 to 14 days, but the other ones are usually significantly shorter. So it usually will get several days of short-term disability taken off the table. So for our clients with large populations, that can make a huge difference from a human capital planning.
Sure.
The next one was from Amy, and I think we may have started to cover some of these, but she was asking, should they recommend that all of their employees have a COVID-19 test if they have symptoms that were either of COVID or the flu?
That's an easy one. That's yes.
Correct, yeah. Is there anything else that you wanted to add to that maybe they should have both types of tests like we were just discussing?
I kind of like what Scott's saying. I mean, Dr. Harry's saying. I agree. I feel like the most important one is whether or not you have COVID-19, because that will really have you out of work for 10 to probably 10 to 12, 10 to 14 days. But I guess from a treatment guidelines, if you did have influenza, then I would probably write a prescription for Tamiflu. If you had strep throat, then I can probably give you some antibiotics. So I'm just thinking more of treatment-based. But again, what Dr. Cherry's saying is maybe referring them to their primary care doctor to get the rest of the workup done is definitely not a bad idea.
The next one was from Jake that was asking how likely would it be, and I think we just spoke about some of this, but how likely would it be for someone to have COVID-19 and the flu at the same time?
Yeah, that's I think Dr. Rezvankhoo was specifically talking about that, and so I don't think we've revisited this specific topic for a couple of months, but I know that was something I actually had come to him before previously to get a sense of what he was seeing in the hospital. But it's definitely some homework for me to do to look at the non-hospitalized population, because we do treat those two different populations significantly different in the case management of them. I think even for hospitalized patients, the concern for them being contagious usually will bring them beyond the 10-day mark to potentially the 20-day mark. But again, looking at potentially seeing if there's an order of magnitude less than what Dr. Rezvankhoo's experience is at that 20 to 30%.
Mm-hmm. Yeah, I definitely think I agree with what you're saying. It's kind of not enough research has been done yet to figure that out.
And then the next was from Paula, was asking, would the treatment be any different for the flu if an employee was positive for COVID-19?
So I think if for the flu. So we're saying you had an employee who has done testing for both influenza and COVID-19, and they were positive for both, correct?
Correct.
Okay, so in that scenario, I would probably treat them with Tamiflu and recommend them to stay home for 10 days because of their COVID-19 and then come back, 24 to 48 hours after being afebrile without a fever, without taking Tylenol or Motrin.
The next one was from Casey that was saying, when can we let an employee come back to work after having the flu? Is there a specific number of days that they should isolate?
I guess I would just recommend the CDC guidelines and what their recommendations are. Scott, I mean, do you know them offhand or for the influenza?
Yes. Yeah, so really there's a significant difference between COVID and flu, and so it depends on which flu, but if and I may have the influenza B, and I'm sorry, I was having a kind of a glitch going on there, but influenza A, I believe, will be 7 days, and then influenza B would be 4 days, and I will just double check that. But again, that's significantly shorter than COVID being at a minimum of 10 days.
The last town hall question that we had was from Joseph, and he was asking, do we need to identify close contact exposures for employees that have flu and or COVID-19? We've done there's been a lot of discussion. We've, had those conversations with clients about, the importance of identifying close contacts for COVID-19 and really doing that contact tracing, et cetera. I think he's asking, is that something that would need to be continued, even if it was something for the flu?
Yeah, there's really a requirement to do contact tracing for COVID-19. I think there's actually kind of at least from a regulatory or a request from the CDC, I believe that's currently, they're silent on that right now. But historically, again, we have a flu outbreak every year, and there has not been like public health engagement by local public health or by the CDC unless it's a novel flu like H1N1 in 2009. And so I think from a requirement perspective, it may not be there, but just because COVID is such a threat to continuity of operations for employers and for businesses, I think being able to fully understand, like through medical surveillance, flu and COVID is really kind of a critical metric for which businesses need to be aware of. So that's not, again, a requirement, but I think it's something that would, again, help companies manage the risk of trying to stay at work, or if there needs to be other types of safeguards put into place.
And I would echo what Dr. Cherry is saying here, because I think and if you look at how medical research is done when it involves surveys, when someone gets a survey, which, let's say this app of how you feel if you're having any symptoms, a lot of that is sometimes we're just clicking the buttons and we're not really thinking too much. But if someone, let's say, had a close contact or close exposure to an individual who was confirmed COVID-19, let's say there are 5 individuals. Those 5 individuals, if they were just to be simply notified and maybe they can pay closer attention to their symptoms, and maybe they can be more accurate with their surveys, and that survey would actually be more valuable if someone told them potentially that there was some exposure so that they can get testing early, and that would probably avoid sort of an outbreak by simply just informing them alone, because usually the symptoms, they could be asymptomatic for up to 4 to 5 days of disease, and so that would potentially help them self-diagnose quicker so that they don't continue working if they happen to become positive.
And then from the perspective of just kind of maintaining things and best practices for their homes, we've been doing a lot of education about, how it is that you need to maybe kind of isolate to one area of the house and separate from other family members that aren't ill. Would that same concept apply then for the flu as well?
Well, I think it just depends. I mean, I'll just speak on my behalf because I've been working in the COVID ICU pretty much almost every day since this mess has happened, and I come home and I'm going to change, and then I go hug and kiss my kids and my children. So I don't isolate myself in some dark place and away from people. So I think that if I was to develop symptoms, this is what I would do. If I was to develop symptoms, then I would get tested. If I'm tested, then I would, at that point, isolate myself and minimize interaction for 10 days to prevent the infection to others. That being said, is it possible that my family members could have gotten infected when I was asymptomatic? It's possible, but it's but the bigger thing is if you do your due diligence when you're outside of the house by wearing a mask, keeping your hands clean, and wiping down surfaces, you can be comfortable that when you get home, if you just change your clothes, wash your hands, do the same thing one more time, you're going to be okay. I wouldn't recommend to kind of go home and self-quarantine automatically, because a lot of times, I mean, I walk into a patient's room that is COVID positive, and a lot of times I'm just wearing a face shield and a mask and then a gown and some gloves, and then once I get out of the room, I change my gown, take off the gloves, wash my hands, and, I'm okay. So it just depends. And, if someone has COVID-19 and they're wearing a mask and you're wearing a mask, the likelihood of you getting COVID-19 is still low, unless you're really in their face, doing a procedure.
Yeah, maybe I'll just add a little bit of discussion here too. Dr. Rezvankhoo, being a healthcare professional, when he's taking care of his patients, he'll wear a mask that has at least a certain level of protection beyond what the CDC recommends for the general population of just a face covering. And so I would assume you're wearing at least an N95 or maybe something even more protective. And so a lot of times, or our view on healthcare workers is as long as they have the appropriate PPE, we do not consider them exposed. And so obviously if there was a PPE shortage, then that would change. And Holly, I don't know if your question was more with regard to the general population than healthcare workers, but I think a strategy would be if someone was actively symptomatic in the household, because household is one of the highest risk transmission venues. We do try to counsel, if the house or the home is large enough, to try to really segregate the sick personnel, in a certain part of the room, and then bring them food and supplies, socially distant, things like that. So I just wanted to, again, highlight those differences.
Let's see. We've got some questions that have came in while we've been talking. The first was from Scott and says, are there any differences in workplace PPE or emergency supplies as we head into the cold and flu season that you perceive as necessary versus the standards that we've been operating under COVID?
I think they're really the PPE is the same. In a non-healthcare setting, it's the same, and probably in a healthcare setting, it's the same, unless I'm missing something. Do you have any different thoughts?
The only time I wear like an N95 mask or a PAPR device is when I'm doing an actual procedure on a patient.
Okay.
involving their airways, or if they're on like a BiPAP mask where they're aerosolizing the virus into the room. But if I'm just walking in and doing a quick exam, I think a simple surgical mask and maybe a face shield is more than enough, as long as, you know, I'm not touching the patient with my dirty gloves and then rubbing my eyes, or, you know, I mean, this is how I think a lot of self-contamination happens. And I think that it's important about how you, I mean, because our hands become contaminated. And so, like, the simple thing of taking your mask off, putting your mask on, where you put your mask on the on your desk, let's say if you're sitting in an area, you're eating food, like how you take off your mask, where you put your mask. So like having clean surfaces and kind of having some sort of a structured process, or that each individual kind of does. Like if I'm going to be using my computer for the day, I normally just give it a quick wipe with a Lysol wipe or some sort of like a bleach wipe, let it surface dry, and then I just kind of go on about my day. So I think these sort of hygiene things are very important for the individual. But I think you know, we wear a regular mask throughout the hospital. And I'm not sure what happens in the workforce, but if everyone's wearing some sort of a face covering or face mask, I think that should be, you're essentially working like a hospital, you know? I mean, that's the only PPE we wear walking around in the hospital, is just a simple surgical mask, which you can get at Costco, you know? In fact, I think that the mask that we use, that they're giving out, is the one that you can buy at, I say Costco because it looks similar. So,
the second part of his question, and I know we're getting close to time, but we'll just do the second part and then we'll wrap up. But was, do you see another shortage in any supplies as cold and flu ramps up, or due to possible political changes in the country? So do either one of you want to
shortage? Shortage of what? Of
he's talking about
masks?
PPE.
You know, I'll tell you, so before COVID-19, the way we used to use these masks was, frankly, quite wasteful. I mean, we would face mask, we would wear one, go into one room, and then we would throw it away. And then we would maybe in another room, we would use another mask and throw it away. And 95s are the same thing. And so now we've gotten to this way of like recycling our masks. And I've been essentially recycling masks since March, and we have not gotten sick, and we've gotten a lot of usage out of our one mask, or, you know, our N95 mask. And so I don't anticipate a shortage, as long as people are being thoughtful about how they're using their masks. You know, I wouldn't. I would try to get the maximal amount of use out of it, if possible.
Sure, anything to add to that?
No, I don't have a good sense of. I know early on there was a concern about stockpiles and this and that, but I don't have any good data. But it is very promising to hear about the hospitals being able to, I guess, more judiciously and more effectively use their current, stocks. That does sound very reassuring to me, but I don't have anything else to add.
Yeah, that was great information. Well, before we wrap up, do either one of you have any closing remarks that you want to share?
For me, I would just say get vaccinated for the influenza at least. Wear your mask when you're out there, and just be smart.
Good point. Dr. Sherry?
Yeah, I agree, and I think maybe I'll just echo again. One of my personal interest is wellness, and so this may be a great time to see your doc or develop a relationship with a personal physician. Get your physical to determine if you potentially are in a vulnerable population. There are many things that can be done to help improve those conditions. acutely and chronically. And so I think it's a great time to where maybe before COVID-19, when we were diagnosed with a chronic medical condition, we just felt very complacent with it. But actually with COVID-19 having these vulnerable populations, it's a great motivator to say, let me optimize my health for the acute risk of COVID-19.
Okay, well, thank you all for attending. We appreciate you joining. I know we had a lot of questions that were here, and if we didn't get to your question today, we definitely will take it in the live stream this next week. But if you haven't already, please make sure and hit that Register Now button on the right-hand side of your screen. That's going to get you signed up for the Recognizing and Responding to Suicide Warning Signs in the Workplace webinar. We also have an additional white paper that's new. You're welcome to access that right there in the Resource tab. That's Risk Stratification of COVID-19. So that really kind of talks about some of the employee categorization of behavioral risk and how it is that you can speak with them about that and really kind of narrow down that safe and healthy environment. So if you haven't already, be sure and sign up for those. We hope that we were able to answer all the questions that you had, and we look forward to seeing you on Thursday. Again, that is at 1:00 p.m. Central on any of our social media streams. Thank you.